Thank you guys for joining us on a Saturday morning. And again, thank you for inviting me. I'm going to cover a talk regarding the medical management of peripheral disease. It's something we do a lot of. And, um, we talk a lot about sort of the clinical facet of medicine, right? And yes, it's doing the procedure, following them peri-op, but really it's adding to your value proposition. And your value proposition to your patient, your community, your hospital system is just so much higher if you're able to take care of these patients comprehensively. And it starts by learning this stuff, right? The pharmacology, the physiology, beyond just the technical. And so when we're talking about PAD, we're talking about a spectrum of disease and our ability to intervene at every point in time in this spectrum to try to affect natural history of this disease process, from asymptomatic patients to claudicants. And really the big thing that most of us treat is chronic limb-threatening ischemia, which without intervention has a horrible prognosis. Right. And why do we care about medically optimizing these patients? Well, one, as a medical community, we do a lousy job, right? And I'll go over some of these numbers later, but as a ballpark average, only about a third of these patients are on a statin therapy and antiplatelet therapy, and they're optimized medically. That's 1 out of 3 in patients who are potentially going to lose their leg in a year or 5 years, right? And so mortality rates in patients with peripheral disease, even asymptomatic peripheral disease, is substantially higher over a number of years than compared to patients without peripheral disease. And CLTI in patients with CLTI who don't undergo an amputation, their prognosis rivals some pretty awful cancers, right? It's pretty comparable. For example, the mortality rate is worse than a lot of cancers. And so you think about it as an arterial cancer. Now, where do we see these patients, right? So in the peripheral space, we always talk about, well, am I going to do peripheral disease or not? This is what's common in the community, and we already see these patients. We just don't think about it, right? And you don't have to have a practice that only does PAD, but you're going to see these patients in the office anyway. And this is sort of, the soul of IR started in the peripheral space, right, with Daughter and Laura Shaw and the first endovascular surgery, right, that he performed. And so when you see patients that have coexisting risk factors, right? A lot of my patients with leg pain, I screen for claudication, and oftentimes there's definitely an overlap in this disease process, right? Our end-stage renal disease patients, a majority, ESRD is a PAD equivalent, right? So you might as well screen these patients and make sure they're on optimal medical care. We all know the risk factors, right? And the good, the bad thing about the risk factors is they're super common, right? The good thing about them is that mostly they're modifiable, right? And you can counsel patients to better health. So diet, smoking, sedentary behavior, obesity, right? A lot of these are so prevalent in our society. The tricky part about peripheral disease and medically optimizing these patients, right, is that there's so much beyond the sort of patient clinician interaction that ultimately impacts this patient's outcome, right? Where they live, honestly, their racial ethnic background, right? So many social determinants of care. We have healthcare deserts 2 hours outside of LA. And so if a patient can't get to me to do debridement, that's going to impact their outcome. So, as their clinician, right, I've reached out to social work. I've helped organize rides so that patients can get to and from hospital setting. I admit them, to my service after an intervention just so that we can make sure they have somebody to pick them up the next day. There's so many barriers to care in this patient population beyond just, oh, they have a long segment SFA, let's go put a stent in, right? So it's something to keep in mind. Diet, right? Eating a healthy diet, right? That's hard enough as it is. Eating like the optimal Mediterranean diet, which is shown to improve outcomes in patients with peripheral disease, is even harder. This is quote unquote a rich person's diet, right? It's healthy greens and fresh foods, organic foods, and a little bit of wine, but mostly lean fish and protein. That takes a lot of money, right? This goes into the social determinants of care. It's not easy for patients to do. Smoking cessation. Only about a third of patients, right? When you see a patient in the office and they smoke, only about a third of patients have even been offered counseling for smoking cessation, right? And we also have great data that shows that, hey, you know what, as a doctor, if you're the one sort of pushing your patient over and over, it takes 7+ times for a patient who smokes to quit, right? And so if you're pushing that patient, eventually you're going to make some headway. You can prescribe varenicline. There's a good RCT showing that it's safe and efficacious in helping patients smoke or stop smoking. Lipid-lowering therapy, sort of staple of any patient with peripheral disease. It stabilizes plaque progression, reduces MACE in males, so major adverse cardiac events, major adverse limb events. And so the staple sort of treatments, drugs are statins, PCSK9 inhibitors, and ezetimibe. Probably in the next 10 years, we're going to see a new mainstream class of lipid-lowering agents, the lipoprotein A inhibitors. Lipoprotein A is implicated in a host of things, including premature atherosclerotic disease, the high rates of stroke, even dementia. So this will be interesting as this class of drugs sort of becomes more mainstream. And in general, right? In general, not for all patients, but in general, your goal LDL is 70. If you have sort of quote unquote advancing atherosclerotic disease, despite optimal statin therapy, you can actually set the goal LDL to lower than 55. Statin therapy, just so much data, right? Tens of thousands, hundreds of thousands of patients. We know that if a patient is on statin therapy, they're less, they're going to have a lower rate of major cerebrovascular, cardiovascular, and peripheral events, lower amputation rates, increased walking distance, right? And we know that high intensity statin therapy is the right option for all patients who can tolerate it. And what does tolerating mean? Well, you check their LFTs, you make sure they don't have myalgias, and that's generally all it is, right? What's high intensity statin therapy? So this is from the HA guidelines, right? It's actually up to 80 milligrams of atorvastatin, up to 40 milligrams of rosuvastatin. Glucose therapy, right? Diabetes, super common, super common. So we see patients all the time in the office come in with an A1C of 14, 15. Why? Because McDonald's is cheaper, right? And it's efficient, and life is crazy. And if you're taking care of 3 kids and working 3 jobs and you need to eat something on your way home, you're going to get fast food, right? And this is clearly, reflected in this patient's population, A1Cs and whatnot. And so lots of good options, lots of good emerging options. SGLT2 inhibitors, GLP-1 agonists, the Wegovy, tirzepatide, semaglutide, etc. They're going to be more important moving forward in everything cardiovascular related, not just peripheral disease, but CKD, cardiovascular disease, heart failure, etc. Goal A1C less than 7, right? And then the most important thing, maybe not the most important thing, but a very important thing in treating diabetics is making sure they get their foot care. This is something that you can easily do in the office, right? Use 10-gram monofilament. You test, 4 or 5 specific areas in the foot. You can detect neuropathy with a 90% sensitivity, right? A 10-gram monofilament costs like $5 on Amazon. It's very cheap, very easy to get. And what you do is you basically put it's monofilament, and you press it up against the patient's skin. And if by the time the monofilament buckles, the patient cannot feel that pressure, they have neuropathy. And by the way, what do? You give them sort of your counseling, right? There's motor neuropathy, sensory neuropathy, and autonomic neuropathy. Autonomic neuropathy causes fissuring, dry skin. This fissuring it can be painful, but turns into ulcers. Autonomic or motor neuropathy can cause Charcot foot, and it can change differential pressures on the foot from the patient's the footwear, and so you want to make sure they have appropriate diabetic shoes. And then sensory neuropathy, obviously, if they have cuts or scrapes, if they injure their foot, they're not going to feel it, right? And all these potentially can lead to ulceration. Antithrombotic therapy. Every patient with symptomatic PAD should be on an antiplatelet. We only do this about 30% of the time. How easy is it to tell a patient, hey, you know what, you should take aspirin. You should be on aspirin for life because you have peripheral disease, you're a claudican, you have an ulcer that we healed. This is going to help you it's going to prevent you from having or reduce the risk of having a heart attack or stroke. I prefer Plavix for secondary prevention in my peripheral patients for the improvement in cardiovascular outcomes. We use DAPT a lot in peripheral disease. In the peripheral literature, the evidence is mixed as far as improving outcomes, but we do extrapolate this. This is all from the benefit we extrapolate from the cardiac literature. The COMPASS trial, low-dose rivaroxaban, Voyager trial, low-dose rivaroxaban in patients with ALI reduces rates of acute limb ischemia after intervention. therapy to improve function, right? I sent all these patients, a lot of these patients to physical therapy. We're trying to set up an supervised exercise program at Kaiser. This is a real challenge, right? Patients with CLTI, they have wounds. A lot of them are not weight bearing. How do they exercise, right? It's so important if we can plug a patient into a professional whose job is to really just help them guide through their physical activity. That is going to improve an outcome. Um, it's interesting, this ACE inhibitor, ramipril, right? For a while, we were really excited about it, but it actually turns out that they withdrew that paper, and there's a redaction in the, I think it's the New England Journal. So ramipril is ACE inhibitors for walking distance, probably no longer a thing. Supervised exercise, we sort of went over that. Largely PAD risk reduction therapies, right? It's a lot of common sense stuff, but what's remarkable is that it doesn't happen, right? And as an interventionalist, you're seeing patients with end-stage renal disease. You're seeing older patients with leg pain that's undifferentiated potentially. The number of times I've had an arthritis patient have claudication and a patient who quote unquote had claudication have arthritis. You can be a one-stop shop and you can manage a lot of these diseases, and you can make your value proposition goes much higher to your system and to your patient if you can adequately medically manage them, right? Prevention, the problem is patients don't really know what PAD is, right? Primary care physicians don't really know their patients have it, okay? Only about a third of patients are taking statin therapy and antiplatelet therapy as appropriate. Smoking cessation only prescribed about 30% of patients, right? And then only about a third of patients who are eligible for diabetic foot screening are getting them, right? And so your job as a expert in vascular disease is not to replace. There's no ego here, right? It's not to replace every other doctor, but your job is your fidelity is to your patient, right? And they're your fiduciary, and you have to do what you can and do what you know and use the totality of your training and knowledge to help them. And you just do what you can with what you have. That's how you start. And hopefully, over a 30 or 40-year career, you've helped so many more people than you would have otherwise. So that's all I have. Thank you.